Welcome to my podcast, Diet, Disease, and Doctor Dialogues. In this episode, you can listen to an internal medicine specialist discuss obesity, focusing on the hormonal and genetic factors that contribute to the condition. Also, a deep dive into medications like Ozempic. Stay tuned for the next 40 minutes as we explore the ins and outs of obesity. Welcome back, Dr. Seema, to Diet, Disease, and Doctor Dialogues. Thank you so much for being here today. Dr. Seema is a fellow of American Academy of Sleep Medicine. Would you like to remind our listeners about who you are and what you do?
Sure. Again, my name is Emmanuel Seema. I'm originally from Ethiopia. I still consider myself Ethiopian. I have an office. A medical office in Beverly Hills, California, and one in Inglewood, California. I specialize in internal medicine, pulmonary, that's specializing in taking care of lung diseases, as well as critical care, that's running an intensive care unit, managing life support and so forth, as well as sleep medicine, treating patients with sleep apnea, insomnia, and so forth. But 80% of my practice is general internal medicine. That's what I'm most passionate about, and I try to focus on that and the many facets of internal medicine.
Thank you for sharing. To start us off, first question, how do you define and diagnose obesity in clinical practice?
So there is a strict definition of obesity, as in many other clinical medical conditions. What the medical community tries to do with each specific condition, and obesity is a disease, is giving it a strict criteria as to what is defined by having obesity. So in this strict definition of obesity, obesity is a medical condition, a disease characterized by excessive body fat that can negatively affect the health. It is typically defined in many areas of medicine. We try to put numbers to objectively assess and categorize conditions, not only conditions, but severity of conditions. So in the case of obesity, people that have a body mass index of 30 or higher are considered obesity, as having obesity. Now, what's the body mass index? It's basically the National Institute of Health constructed this concept idea that we take one's height and one's weight, and we basically pigeonhole them into a category. Obviously, if they have, for their specific height, a weight measurement that is higher than a specific level, then they'll be considered obese.
To segue from how you define obesity from the medical professional, what are the most common misconceptions about obesity that you encounter among patients?
Well, the number one thing is that the misconception is that most people that have issues with obesity don't perceive as having a disease, a condition. They consider themselves healthy, maybe, quote unquote, or a bit overweight, as I often hear. But they don't correlate. Most people, not all, most people don't correlate their obesity with potential short and long-term clinical medical complications. That's the biggest misconception about obesity.
Can you describe the main causes of obesity, including genetic or environmental factors?
Yes, so there are many causes of obesity, but the primary driving factor is genetics. Genetics can influence how our bodies store fat and respond to hunger and to satiety signals, meaning when we eat, at what point do we feel full? Some of us sooner than others. So satiety signals are also driven by genetic factors. Some people are genetically predisposed to gain weight more easily than others. Other factors are poor diets, having a diet high in cholesterol or processed foods, sugar, primary driving force, sugar, unhealthy fats, and foods that are low in nutrients but high in sugar, which can contribute to weight gain. Other factors are also lack of physical activity, sedentary lifestyle, such as excessive screen time and limited physical exercise or desk jobs, can certainly lead to weight gain. And other factors include psychological states. People who are stressed or depressed or have the tendency to have emotional eating can gain weight a lot easier, I should say, than people who don't. Hormonal imbalances, hormones like insulin and cortisol and leptin can influence weight gain. Conditions such as hypothyroidism or polycystic ovarian syndrome, ovary syndrome, PCOS, can also contribute to obesity. Other factors include environmental factors. Living in an environment where unhealthy food options are easily accessible, or where exercise options are limited. These are factors that increase the likelihood of becoming obese. Medications such as antidepressants, corticosteroids, insulin. These are medications that can contribute to weight gain. Another often overlooked factor is sleep or lack of sleep. Chronic sleep deprivation, poor sleep quality can lead to weight gain through hormonal changes that are brought on because of chronic fatigue and lack of sleep, which actually cause hormonal imbalances. So these are the factors that can contribute to obesity.
So, for these patients with obesity, what would the current medical or lifestyle treatment options be for them?
Okay, so the one thing is that the biggest issue with obesity, and these days, because of the advent of new medications such as Ozempics, people tend to jump on that idea of just being on a medication to lose weight. But in the clinical setting, the first thing that we do as physicians is to allow the patient and to instill in the patient the concept of self-monitoring, tracking food intake, physical activity, increasing physical activity, building awareness of habits in terms of habits of exercise, habits of avoiding junk food, maintaining and monitoring a food diary of that tracks food intake. These are the baseline that we try to institute in terms of the therapeutic approach. And then we explore with the patient what we call stimulus control, identifying and avoiding triggers that lead to overeating, such as stress reduction, and behavioral changes through self-assessment and self-education. And then the third approach is what we call goal setting, and that is establishing a realistic and specific weight loss goals. Often when one starts on a weight loss journey, it is often that they face the reality of very gradual weight loss, and their expectations need to be managed. One cannot and should not expect to lose 10 pounds in a week. So the physician interacts with the patient and creates a realistic chart, if you will, of a weight loss goal, perhaps 3 pounds a week or 2 pounds a week, something that is achievable easily, if you will. Otherwise, the patient gives up and just walks away. So we have to really adhere to what we call managing expectations. The other thing also is problem solving, addressing challenges and having a open channel with the patients to answer questions. Often patients may have questions about diet. They may have a favorite food that they like to eat 2 or 3 times a week. Is it good? Is it not good? How much, if at all? So these are things that, problem solvings and interactive sessions with the patients to number one, teach them, number two, encourage them, and number three, validate their fears and their angst, if you will. And so these are everything I've talked about until now does not involve medication. These are basic approaches that any doctor's office can do without having any special medications or special instruments therapeutic instruments, if you will. And then we tend to involve also nutritionists and dietitians to have what we call cognitive restructuring, challenging negative thoughts and attitudes about food and body image and so forth and so forth. Social workers, psychologists, dietitians. So as you can imagine, this involves a group approach, a team approach, if you will. And then also having the family and friends involved, encouraging, supporting, friends and family and support groups. So that's where we begin in terms of the therapeutic approach. And then we go into dietary interventions and then go on to, other treatment protocols.
Maybe like a step further from like the behavioral therapy and what would need to be taken after that.
Okay, so as you know, the new class of medications that have really revolutionized and changed the diet market and the weight loss market are called GLP-1 receptor agonists. So what are GLP-1 receptor? So GLP-1 stands for glucagon-like peptide. Glucagon-like peptide 1 receptor agonist. So it's a hormone, basically. GLP-1s are hormones that play a crucial role in regulating blood sugar levels, appetite, and insulin secretion. It's part of what we call the incretin hormone family. This helps the body manage glucose levels after eating. And now, imagine this under normal circumstances. So when we eat, as food enters our stomach, there's a signal sent to the body that says, hey, glucose is coming in. We need to manage what we're going to do with it. Are we going to use it? Are we going to store it? And so this hormonal system, this hormone signal system is called incretin hormone family. So the keys to GLP-1 are, number one is enhancing insulin secretion. When blood sugar levels are elevated in the blood after eating, GLP-1 stimulates the pancreas to release insulin. Insulin, as you know, is a hormone that helps lower blood sugar by allowing our cells to take up glucose. Now, GLP-1s allow insulin to be secreted, and they inhibit the release of glucagon. Glucagon is basically the exact opposite hormone of insulin. GLP-1 reduces the release of glucagon. Glucagon is a hormone that raises blood sugar levels, particularly during fasting times. So when we eat, insulin is raised. When we're fasting and we are there's no food in our stomach, glucagon is released so that the blood sugar levels don't go below a certain level. Remember, as in many things in our body, the sugar management system, if you will, or homeostasis, to keep sugar between, let's say 80 to 120 or 115, 110 at all times, involves the yin and the yang. What are the yin and the yang here? Insulin reduces blood sugar when blood sugar enters from our gut after eating, and glucagon, again, insulin reduces the glucose level when the glucose level goes high after eating, and glucagon raises the blood glucose level when there's nothing in our stomach and the sugar level, the glucose level in our blood goes down. Okay, yin and the yang. So GLP-1s they actually manage the yin and the yang in a certain way. They cause the release of insulin when the blood sugar is raised, so it comes down, and they inhibit glucagon so that the sugar levels, there's nothing counteracting that reduction in the action of insulin in reducing blood glucose levels. Now, GLP-1s also do other things. Other things include slowing gastric emptying. So GLP-1s delay the emptying of the stomach. Why? This helps people feel full earlier and reduces hunger. This is particularly useful in weight management. This is very interesting. So when we eat, under normal circumstances, when we eat and our stomach is full, GLP-1s reach a certain level and the stomach sends a signal to our brain, go, we're full, stop eating. So in this case, when one takes Ozempic or other type of GLP-1 agonist, so what happens is before our stomach is full, because GLP-1, now because of the additional, the stimulation of the secretion of GLP-1s through this medication, the GLP-1 levels are higher than they would be because we're taking and we're administrating GLP-1s. The stomach tends to feel full a lot earlier. And that's the key. That's where weight loss comes. A patient or an individual who takes GLP-1 agonists almost always feels full. So they eat a lot less because their perception is, hey, the stomach is sending a signal to my brain. Of course, they don't think that way, but the body's thinking that, hey, the stomach doesn't need any more food, even when the stomach is empty. So another action that GLP-1 agonists do, they actually suppress appetite. So they increase insulin, they decrease glucagon, they slow gastric emptying, they suppress the appetite, okay? And likely because of through the action on the brain's hunger centers, helping with weight loss and weight management. So, and another action is it promotes, GLP-1s promote insulin sensitivity, which means insulin sensitivity means patients with type 2 diabetes, for instance. The problem is not in lack of insulin. If you check a type 2 or adult onset diabetic's insulin level, is it going to be high, normal, or low? It's going to be high because the body has become insulin resistant. The cells are not responding to the insulin being secreted and trying to open that door so glucose can go in to the cells. GLP-1s actually increase glucose sensitization, which means that a patient with diabetes who takes GLP-1s has the tendency to respond to insulin, their own insulin better, and so thereby reducing blood glucose levels. So in summary, GLP-1s have become a game changer in the industry of diabetic management as well as weight management.
On the topic of like GLP-1 agonists and Ozempic, which is getting a lot of attention right now, is there any concerns on safety issues about Ozempic and about the patients that are using it?
Okay, so yes. So what are so let's talk about the side effects first. Mm-hmm. So what are GLP-1s? In terms of medications, okay, let me go back and say something that's very important, and that is how and in what way did the GLP-1s come to market? You see, for decades, many decades, the pharmaceutical and the medical industry grappled with one huge problem when it came to the management of adult onset diabetes. Mind you, again, I digress a bit, but type 1 diabetes is what we call, juvenile diabetes, and type 2 diabetes is adult onset diabetes. These two conditions are completely separate. I mean, they should not even be called the same name. Type 1 diabetes, juvenile onset diabetes is a process where when mostly in the first decade of life, when kids come down with viral illnesses mostly, and somehow the immune system cross-reacts with the pancreas and kills the pancreas. So people with type 1 diabetes have no insulin. It's a deadly disease. Type 2 diabetes, which we've been talking about in this session here, is a completely different pathophysiologic process. Type 2 diabetes is a genetically driven condition where, for whatever reason, when patients reach the fourth or fifth, usually the fifth or sixth decade of life, the body stops responding to insulin efficiently. Remember what we talked about, right? Food goes into the stomach, gets absorbed into the blood system, insulin is secreted, and insulin drives the sugar out of the bloodstream into the cells. With type 2 diabetes, that process where insulin goes into the cells and tries to open the door to get sugar in, as soon as it gets there, it tries to open the door for a genetically driven reason mostly. These types of patients, the door doesn't open. So sugar goes up. So insulin has to go up higher to try to force the doors of these cells to open so sugar can go in, glucose can go in. One of the other ways that, other than genetics, it's a big factor here, other than genetics that drive these in what we call insulin resistance, is obesity. Most morbidly obese patients are diabetics, and most of them don't necessarily have that genetic predestination to be diabetics. They just happen to be morbidly obese. Obesity itself is an independent risk factor for the development of type 2 diabetes. Okay? So, I go back to the historical advent, if you will, of GLP-1 agonists. So for decades, the pharmaceutical industry and the medical industry grappled with one huge issue, and that is when someone develops type 2 diabetes and the medications that we give them, whether it's a tablet, like sulfonylureas, such as glipizide, glyburide, glimepiride, or insulin, most of these classes of medications caused obesity. The reason why is almost all of these medications worked through the insulin pathway. The only thing they did is go into the body and squeezed or pushed, except metformin, that's another class, particularly the sulfonylureas and insulin families, they basically elevated the insulin level in the blood to a very high level, overwhelming the cells and forcing the cells to open their doors so that glucose can go in. Now, the problem with that, whether you give insulin to raise the blood pressure, or whether you give a sulfonylurea, such as a glimepiride, glyburide, to squeeze more insulin out of the pancreas, insulin is what we call a trophic hormone. You know what that is? A trophic hormone. Okay? What a trophic hormone means is that these are classes of hormones that promote fat production and fat storage. That's one of the things that insulin does, meaning that insulin, it drives sugar from out of the blood into the cells, and it causes the liver cells also to take up more insulin, more glucose, and that glucose is converted into fat and stored in fatty tissues. So if you've ever seen a severely diabetic, type 2 diabetic patients, what are they? Are they thin or are they obese? They're actually thin because glucose runs right through them. The body's not using them because the body's not responding to insulin. That's why a lot of uncontrolled diabetics pee. They're thirsty. They drink a lot because the body is trying to wash that glucose out of their body. That's a misconception. The reason why they drink is because the kidney's trying to get rid of as much glucose as possible, and with it come water, and so the patient is dehydrated, so they have to drink more water. So, and then we come along, we give them the medications that we give them to control the sugar. The side effect is weight gain. So GLP-1s really solve that problem, because what they do is they have a plethora of pathways that they control sugar while at the same time reducing food intake, curbing appetite, as well as promoting insulin sensitivity, reversing that type 2 diabetes process of insulin resistance. These are wonder drugs. Now let's go back and look at what are they. GLP-1s, basically, there are 4 drugs or generic pharmaceutical names for it. Semaglutide, tirzepatide, and then there are exenatide and dulaglutide, and those are, dulaglutide is Trulicity, exenatide is Byetta and Bydureon, semaglutide are Ozempic and Wegovy, and tirzepatides are Mounjaro, and these are in the drug names and the trade names, Mounjaro and Zepbound. Also, Rybelsus is tirzepatide. And there's another one called liraglutide, which is Saxenda and Victoza. So you don't need to know these names, but there are different types, but they basically just do the same thing. Ozempic has become widely known as the weight loss medication under the brand Wegovy. Semaglutide has become widely known as a weight loss medication under the brand name Wegovy and Ozempic, because they were the first ones to be promoted. That's why it became sort of in and of itself a generic name. When someone says Ozempic, it basically means a whole class of different, the whole class just basically is called Ozempic these days, I believe. But it is also, these are also being used to manage type 2 diabetes. And so going back to the side effect now, I hope I'm not going all over the place, but I do remember your last question of what are the drawbacks, what are the side effects. So basically, while GLP-1 agonists can be very effective, they do come with potential side effects. And the most common side effects are gastrointestinal issues, such as nausea, vomiting, diarrhea. These are common. Constipation is also common, primarily because people not only don't eat much, they also drink water much, so they get dehydrated, and that in and of itself can cause constipation. Also, they do have, these are diabetic medications, so they can cause hypoglycemia, i.e. low blood sugar, particularly if used in combination with other diabetic medications to manage diabetes, especially the sulfonylureas, as I talked about. There is a risk for hypoglycemia, which is a dangerous side effect. Other things, as you know, these are injectables, so you can have injection site reactions, irritations, discomforts, and a rare but documented side effect can also be pancreatitis. They can inflame the pancreas, and that's also a bad side effect. But overall, these are, most of the side effects are manageable. There are rare side effects, such as the pancreatitis I mentioned, and then that can be managed as well. In terms of long-term risk, as you know, these drugs are only a few years old. They're about, I think they came out in 2018, so they're about 6-7 years old. So it's too early to really tell, what those reactions or side effects are. Now, what is very interesting is that, I don't know if you've been listening to the news, GLP-1s are being used in a variety of other conditions. Really, these drugs, and by the way, I must fully disclose, I'm not sponsored by anyone. This is my opinion, without any influence from outside, financially or otherwise. This is purely my approaches from the medical, clinical benefit versus risk factors, or perspective, if you will. Now, having said that, these drugs are being used in a variety of other clinical sectors. They're shown to benefit people with chronic kidney disease. They reduce cardiovascular disease. They are used in drug rehabilitation centers. For instance, I told you about how they reduce satiety and craving. So what we have found is that if you look at people that are, recovering from drug addiction, be it opiates or cocaine or heroin, opiates again, or methamphetamines, the first initial detoxification is easy. The biggest, or alcoholism itself, or cigarette nicotine addiction. So the biggest problem is not the short-term detoxification process. We can do that easily with the proper therapeutic setting. What we fight against very hard and often lose that battle is curbing the craving, the appetite that patients, these victims, have long term. Okay, once an opiate addict, and this, I'm sure you've seen it in the news, I'm sure many of you out there have had friends, family, people, associates, or you've heard about how someone is clean for a year and all of a sudden they're found dead with an overdose from an opiate. So that craving will never leave. That's where the addiction is. It's a disease. That craving is something they can never shake. And we've had problems in coming up with therapeutic options, medications that will reduce the appetite and the craving, and that can, eliminate the craving. And what we have found is that GLP agonists play a significant role in these clinical settings in curbing people's appetite for drugs, just as they do for food. Okay? Let me say something, just to give you an example. The other day, a patient of mine came in. They've been on a therapy on one of the GLP ones. They've lost about 32 pounds. They're looking and feeling great. So we agreed, said, I think you're done. So what we do in my clinic is we just set a goal and create a target, a target weight. And when they reach that point, we stop the medications. And there's a variety of ways of stopping. We give them the option of weaning down and weaning off, or if they are so inclined, it's safe to just stop the medication. It depends on how they want to approach it. We try to personalize it. This individual decided, hey, I am great, I'm doing well, I'm exercising, I'm diet, and I'm watching my food intake, and I've lost weight. I want to get off this medication. And I said, fine, I agreed, and we stopped. It did not take him half a month to come back. And he had gained a couple of pounds. But what concerned him the most, and this is an individual who lost 32 pounds, and that's not easy to do, but he did it. But what was so bothersome to him is that all of a sudden he said to me, I'm sitting at lunch eating and I'm planning my dinner. What we call constant food noise. He started constantly thinking about food. And so, in just the same way, imagine a drug addict, an opiate addict, who thinks about opiates all the time. After he detoxed and he or she comes out of rehab, that craving never goes away. So these drugs have become a powerful tool in controlling or curbing appetites of any type, meaning drugs, alcohol, nicotine, and food. So these drugs have been really in use at an increasing rate in drug recovery centers.
On the topic of other related conditions to obesity and obesity medications. What are some like major health conditions associated with severe obesity that patients should be aware of?
In terms of health conditions,
Yeah, like related to obesity.
very good. So, obesity, diabetes, as we extensively talked about it earlier today, hypertension, obstructive sleep apnea, a topic we covered at length during a previous episode. Arthritis, particularly the knees and the hips and ankles, because the body, those joints are carrying a large load, a much larger load, heavier load than they should, and they're designed to carry. And so these are some of the complications of obesity. And each condition also has sort of a snowball effect, right? A morbidly obese patient could be diabetic, hypertensive, and in the long term, that subsequently will cause kidney failure, heart failure, and or stroke. So there's a myriad of clinical conditions and complications that can manifest because of obesity.
So, with the rise of like mobile phones and iPhones, how do you see the role of wearable technology and apps in monitoring and supporting weight loss efforts?
Excellent question. So, wearable technology. I don't think many people are aware of what we're talking about. So let me give a brief, basic explanation of what a wearable technology is. Wearable technology has become an innovative and valuable tool in managing obesity, as it helps individuals track their physical activity, monitor their diet, encourage healthier habits, if you will. And these devices can offer real-time feedback and support long-term behavior changes, making them a popular choice for people trying to lose weight or maintain a healthy lifestyle. There are some examples of these devices. The biggest one is Fitbit, right? These are called fitness trackers or activity monitors. Fitness trackers are some of the most widely used wearables for managing obesity. They typically monitor daily steps, calories burned, active minutes, and heart rates. Sleep patterns, and so there's a variety of clinical parameters that these devices can monitor as a way of encouraging, supporting, having the ability to monitor one's activity. There are the brands such as Fitbit, Garmin, Apple Watch are some of the more common brands. And they help in a variety of ways. Like I said, they motivate, they create accountability. Fitness trackers can provide daily reminders and milestones, which can help individuals stay motivated and aware of their physical activities. Goal setting, trackers can set their personal fitness goals, if you will. Hey, I'm doing 2,000 steps a day now. I'll be, doing 10,000 steps in a month per day, helping users stay focused on their weight loss and maintenance objectives. And the biggest thing also is data tracking, right? So these devices can sync with other apps to track long-term trends, so users can see improvements in their activity over time, which can motivate and help with behavioral changes.
On that note, I wanted to end their time together. Thank you very much for this detailed explanation of obesity and everything that goes with it. Thank you very much.
Thank you, and keep up the great work, Naomi. These are excellent venues that can promote health and good health and betterment of health, if you will.
That brings us to the end of the episode. Today, we explored the complexities of obesity and diabetes, breaking down the underlying factors as well as behavioral and pharmacological therapies. We also took a close look at glucagon-like peptide 1 agonists, like Ozempic, its numerous applications, how it works, and why it's a game changer for both weight management and metabolic health. For now, remember to stay curious, stay safe, and until next time, this is Naomi Faleka signing off from Diet, Disease, and Doctor Dialogues. See you soon!